Hi, everyone. I'm Maggie Runyon. I am a perinatal nurse and nurse educator talking about trauma-informed care in a host of different events to nursing professionals and healthcare professionals. And I'm really excited to talk today with you about trauma-informed and responsive nursing education, understanding trauma and our nervous system. How we show up for our nursing students is a topic near and dear to my heart, both as a former nursing student and as an active nurse educator. I think we have so much potential to really change the way nurses feel about themselves, about our care, about our well-being during this work. And this is really a powerful opportunity for us to connect around this. So thank you for being here with me. I am going to move my face out of the way so you can see the rest of the slides, but I'll be here chatting with you. So, today we are going to be talking about appreciating the impact of various types of trauma on nursing students and its contribution to psychological distress, and also how we foster trauma responsive educator techniques to improve student well-being. So, truly, I'm here to uplift you and provide some ideas and tools to best respond to the psychological trauma your students and those you're educating may experience, and to share some research best practices, insights from students and new graduates around the country on what they want from their educators. And I hope that as you process this, that you'll feel free to reach out as you have ideas and want to exchange any of them with me. So, why am I here? One, I'm honored to educate. I truly think it is one of the most important things we can do to give back to our profession. And so I'm grateful to share this space with all of you who are in a similar journey there. So, my time as a student, a nurse, and an educator all inform this work. I really believe the foundation of our education is crucial to supporting our nursing workforce. I feel lucky in many ways about the nursing education that I received and the way I was supported by, my nursing faculty members. And I also have seen and learned things in, the interim that informs the way that I want to show up for students and how I want to and change that. And so I think there's always opportunities for us to learn more, to improve how we're connecting, and to also just acknowledge the realities of our healthcare system, where we are at right now, how things are different maybe than they were when, we went through nursing school, different challenges that are facing our students that need to change to, so that our practice needs to change to best support their practice. So I invite just a moment of reflection here for you. How are you feeling as an educator? Are you struggling too? Truly, this focus is about you. So I invite you to pause and reflect on these questions for a moment. How do you connect with your students? How do you identify authenticity in your work with them? And I want to acknowledge that, everyone is holding multiple things right now, right? Each of us has personal and professional experiences, challenges that we are going through. And it can be difficult to parse out how we're showing up for our students through everything else that we're holding. So let's hold ourselves gently as we move through the rest of this. Here's a little bit about our time together, what we'll have over this presentation. So we are going to start with some neuro drills, some things to protect our nervous system a little bit, to prepare it to open and close our time together. We are not going to share any graphic patient stories or images. We will be talking about some current pitfalls to really having a connected and engaged nursing education space. There will not be any non-consensual participation, those of you catching this recording, and handouts are available to support this work. So let's dive into those neuro drills. So neuro drills being a term to refer to how we can sort of try to intentionally downregulate our nervous system, recognizing the co-regulation that is constantly happening with us and anyone we are sharing space with, whether that is, online or virtual, thinking about how we're going to ground into this learning space together. So we'll start by doing some deep breathing. And as you kind of settle into your breath, just see what happens naturally. There is certainly not a right or wrong way for this. Different things feel good to different bodies. I am going to invite us to think about extending our exhale as you keep going. So maybe you're breathing up to 4, 5 on the inhale, and then breathing out, lasting a little longer. maybe going to 6, 7, and keeping that up, noting and holding space that for some of you that might feel uncomfortable, right? That might activate something else in you that might not be something you want to engage in. So certainly listen to your body and what feels best to it. And then once you've settled into a breathing pattern that feels comfortable for you, I want to just invite some body awareness. So think of how you're sitting or laying, resting, standing right now. How is your body feeling? Anything you need to tweak to make yourself more comfortable, to settle in for this time together? And then finally, I want to invite you to do some havening. I'm going to bring my face back for you all so we can see this together. So havening being like one way of thinking about like feel good touch, right? So with the intention of self-compassion and caring for ourselves. So we do that with like long, slow strokes on our body. So there's a couple different ways we can do it. You can do it on your face, right? So you can take your hands and just go nice and long, slow, coming down your face. That can feel good for folks. You can do your hands and back and forth, right? Getting some good oxytocin going. You can do your arms, right? Bring your hands slowly down your arm. You can do them across your body at the same time. That does all sorts of cool stuff for our brains as well. So whatever feels good for you to get a little oxytocin flowing, establish your safety here. All right, you're welcome to pause the recording and keep going with that for as long as you want to settle into this space. So next, we'll just be reminding kind of a definition of trauma. There are many definitions. This one comes straight from SAMHSA, the Substance Abuse Mental Health Services Administration. So they say that an individual experiences an event that overwhelms the nervous system's ability to cope and has lasting adverse effects on the individual's functioning and well-being. So this is sometimes called the 3 E's definition of trauma, right? There's an experience of an event and it has lasting effects. So noting with this that this is intentionally very broad, right? Our bodies recognize trauma in a multitude of different experiences. Folks can go through the same event and have very different experiences of it. That does not make anything more or less valid. So just remembering that there are certainly some things that we've kind of come to universally understand to be traumatic, but in general we want to just recognize that there can be individual trauma, vicarious trauma, childhood trauma, community and generational trauma that can all impact, folks in different ways. And so we want to just keep openness around understanding that. And I also want to dive, get our nerdy theorist caps on here for a moment. So this is a theoretical framework from Dr. Karen Foley. She is a nurse, researcher. She's done a ton of work around trauma, psychological trauma. And this is her recent theory, the middle range theory of nurse psychological trauma. So I know this is a busy graphic here, and we'll break some of this down a little bit later. But I just want to highlight a couple of things. So one, noting here at the top that, right, we have this understanding of this neurobiology of trauma, right? The event experience effects that we just talked about. We recognize that there's all these different, types of trauma that show up in different places. And then on this right side, these are the specific ones that she has identified within the nursing workforce that can show up for us. So we have vicarious or secondary trauma, which is typically the most kind of widely understood, studied within nursing and healthcare to see how trauma shows up. There's also historical trauma that can be associated with our role, with how much power we've held within the healthcare system. There is the impact of workplace violence, right? Bullying. We might have talked or heard about, nurses eating our young. Perhaps many of us have experienced it. There's also system-induced trauma, which is kind of particular to things done within the healthcare system, within the treatment that is chosen for someone that causes trauma to the patient and then, to the nurses as well. There is insufficient resource trauma. Certainly one we're all probably unfortunately very familiar with. So just recognizing how it feels to try to do a job and not have adequate resources to do it. There is second victim trauma, which sometimes kind of gets confused or kind of muddied with vicarious or secondary trauma. But second victim trauma, really noting that this is something that happens. We often think of it kind of akin to moral injury or for, someone who's had like a medication error is a big one, right? So that there was a med error and, whether or not the individual, the patient experience trauma from that. The nurse, the healthcare worker holds a lot of trauma around what happened there or the potential of what could have happened. And then there's trauma from disasters. So certainly thinking COVID is one that pops to our brain, but other ones that we experience, folks who are going through perhaps out in in California with wildfires that have been going on lately, certainly in any sort of natural disaster, then what occurs from that. So all of these are different types of trauma. So there were 7 different types of trauma here that Foley has identified as kind of explicit, separate things we can. So when you think about that, there's a lot of potential causes for trauma within our work as nurses, and we just want to be holding that reality, whilst also recognizing over here all these different things that help to buffer it, right? So there are the things that can make it a little bit worse, right? Can make it more challenging with staff turnover and substance abuse issues and things that we turn to deal with it. And there's also the potential, certainly, to grow from this, to develop more resiliency, to experience post-traumatic growth, and to recognize the impact of trauma-informed care for nurses and patients, which is, what we're doing here today. Okay, so question I've heard several times when talking about, trauma and when we pull out trauma-informed care is, how do we know when trauma is bad enough to necessitate us pulling out all the stops for our trauma-responsive approach? Right, so trick question, right? We don't, right? I don't know when something is bad enough. I trust and believe the experiences of those around me, right? And that's what we're asking for you all to do too. And it's difficult sometimes within academia and, as nurses when we are very conscious of, the importance of nursing education and how it prepares folks to provide safe care. There has sometimes been an undercurrent of students needing to really justify everything that's gone on for them, every way that they're showing up to folks to kind of make a perhaps to validate why they are or are not, coming to clinical, why they're asking for an extension for something, why they need to do that. And, some of that can really ask people to really spell their trauma out for us in ways that are not helpful or healing to them, in ways that can actually cause, more injury. And so part of what we're talking about today is just rolling out these trauma responsive nurse educator techniques that we can apply for everyone, right? Off the bat, automatically, we are assuming that, the unfortunate reality is folks will experience trauma throughout their lives. We're holding that understanding and trying to show up with our students and with each other in ways that just recognize, yes, we are all going through difficult things. Being a human has a difficult experience, and we don't always need to know all of the details behind someone's current personal experience to just support them and to show up with techniques that provide a little bit more flexibility, that allow for the nuance of all of our particular situations. So we're going to talk a little bit more about understanding how these signs of trauma show up so that we know when we need to kind of go up to that next level, beyond our kind of universal approach of it. So another note on that is big T and little t trauma. I'm sure some of you have heard of this concept before. And I just invite you to kind of think through what you think of this list. We'll note that there are some things kind of off to the left that maybe we think of as big T referring to that idea of kind of what are more universally accepted as like, oh, yes, most people who experience something like that will have some trauma related to it. So that includes, physical or sexual assault, natural disaster, intimate partner violence, war, child abuse, death of a loved one, some life-threatening illness. And then over to the right are some concepts that are sometimes referred to as little t traumas. To be clear, I do not love that. I think it can sometimes minimize the effects of certain events and make it seem as if some people's trauma is more or less valid, which is not. It's not true. That's not accurate, and it's not how it's perceived by our body. So those might include, but job changes, infidelity, financial stressors, family secrets, loss of relationship, interpersonal conflicts, work stress, shame, humiliation. That said, this is, anyone could maybe move some of these from one side to the other, which, really just exemplifies the point that this is, a non-exclusive list. These could be, categorized in a number of ways, and we just want to be open to, really understanding and showing up with the person who is in front of us, regardless of the specifics of what they have experienced. These are some of the things we see show up as trauma within nursing education. And, there's this intersection of traumatic experience that is, inescapable in a way in healthcare. We'll see off to the side, we have some things that, patients may experience, off to the right, things that students may experience. And again, noting any of these could be going back and forth from one case to the other. So, we know that when we take care of patients who have, are going through, maybe they've been part of a motor vehicle accident, right? There's been a demise, there's been a loss, they've had stroke, a cancer diagnosis, right? We might expect that we are going to, have that's going to be traumatic for them, and that hence we might be at a slightly, increased risk of experiencing, vicarious or secondary trauma. And, we see that on student side, they're, might be experiencing a bad outcome with a patient, right? Especially unexpectedly. They might have their own death of a loved one. They might be experiencing bullying. They might be struggling with their academics and be on probation. They might have made an error, right? They might have the end of their own relationship. They might experience patient death, right? And all of those things we might be kind of more aware of and tuned into. And then all the things that are kind of below our little iceberg image here are to help us really remember and tune into all of the things that be happening beneath the surface for both our students and the patients that they care for alike, right? All of these things, histories of abuse themselves, of neglect, other negative experiences they've had in the past that could be reactivated by some of their time in, nursing school or in caring for a particular patient. And just a reminder that while there are some traumas that are more easily recognized by others, it does not make them more, valid than those ones that are hiding under the surface. And that while we can attempt to, sometimes separate our personal from our professional, our nervous system does not differentiate, right? It perceives threats to safety and connection when toxic stress starts to feel familiar, right? And that can show up unexpectedly. And this is true for us as educators as well. We are, unfortunately not excused from that either. And just noting that all of these are highly subjective, and it can be helpful to talk through that reality with our students as well. So a reminder about, some of the different stresses, types of stress that occur, right, and how they relate to trauma. So, we think about kind of positive stress, right? We see the image of this person here, maybe waiting for like a job interview, right? Or the first day of a new job. So maybe you're preparing for a meeting. Maybe you're giving a presentation to a bunch of folks like I am today. So we might experience, a brief increase in our heart rate, right? Mild elevation of our stress hormones. And, that's designed to, right, to keep us safe, to have us kind of on a top of our game. And then the next piece is tolerable stress. So this is serious, but it's a temporary stress response. And it's, typically going to be buffered by other supportive relationships we have, by other coping mechanisms we have. And we're anticipating that it is going to end. So as we're working at this slightly, increased pace, we see a deadline coming and know that there will be a relief for our system. And then toxic stress, right, what might be experienced by the person on the right, that's when that tolerable stress, it doesn't go away, right? Perhaps that deadline does not bring the end of the stressful situation, right? And it's severe enough to start to change our brain's architecture and how we respond to other stressors. And then there's the kind of stress that comes from historical or generational trauma, right? Racism, colonialism, genocide, all of those things. Those events also live at the cellular level, and they can transform what, how we behave. They are passed down from generation to generation, and we see these epigenetic changes continue on and on and on. So just recognizing that any of the students and folks we might be supporting, they can be dealing with a host of these different types of stressors, all at once in their life, and it's going to change how they are able to show up. Another way of thinking about this is through our window of tolerance. So a window of tolerance we see here in the middle is pictured with our river, right, where our little unicorn raft is floating down. So, we think of being on this river. When the river off here to the right, it's really open, it's much more calm, right? It feels safer, it's balanced, right? We feel good, right? When we have this wider window of tolerance, right? But several things can shrink that window of tolerance, right? Can make it more narrow, where it starts to feel fast and unsafe, like it would if we were on the river, right? So stress and trauma can cause that window of tolerance to shrink, right? And as more stress or more trauma is activated, that's going to get smaller and smaller and smaller until it feels very, very unsafe. And when that happens, we enter different states of dysregulation. So you'll note that we become dysregulated in kind of two directions. So if we go up to the top, we become dysregulated. Outside, we might feel agitated, anxious, angry, right? We're not comfortable. We're not completely out of control, right? And that's before we get to hyperarousal, right? So this is an abnormal state of increased responsiveness. It is intended, right, to keep us safe. But what we feel is very anxious, angry, out of control. We are waiting for something bad to happen. We might have that fight or flight, running away response that gets activated in those states, right? And we feel like we need to escape the situation to get out of that. And then the other way we can dysregulate is kind of to downregulate, right? Where we start to feel really overwhelmed, right? We start to shut down, we lose track of time, not feeling comfortable. And this is different from like the happy downregulation we do to just like say, hey, we're safe and we're calm and balanced. This is where we are so overwhelmed that we can't think of really what to do next. And then eventually that can lead to that abnormal state of decreased responsiveness called hypoarousal, right? Where there is just numbness, exhaustion, depression, and it feels like our body is shut down. We are frozen. We cannot take, steps necessary to move beyond that. And this is another one that can be helpful as, something to show and share with our students to think about and to tune into their own feelings as well, to recognize when they're starting to have that narrow window, to think about how they can expand their window of tolerance. How does meditation, listening to music, engaging in our hobbies, spending time with our friends and loved ones, how does that change and create, more calmness? How to doing some of those neuro drills maybe help us to expand that window of tolerance and bring ourselves, back to being a little bit more balanced. So with all that said, remembering that, truly the job of our nervous system, right, the way the brain keeps us safe is to develop patterns and predictions, right? And becomes very efficient at this, where there is a perceived threat, and then that leads to a stress response. And our brain is constantly predicting. Every second to second, it is guessing and pretty accurately often at what is going to come next. And so when it's doing this predicting and it's starting to sense what is happening, there are several stress responses that typically will pick up if it is sensing danger, if it is feeling unsafe. And the four that we're going to talk about today are the fight, flight, freeze, and fawn. There are several other stress responses. This is not, exhaustive list, but these are ones that show up kind of commonly. So we'll focus on them for now. So first one is fight. Okay, so this is someone who goes on the offensive. Fight is what's telling us it is all their fault, right? Someone else's fault, and I'm going to fight back to get control and safety. So this shows up by, angry outbursts when we demand perfection from others. We speak in a demeaning way to other people. We try to control or blame others. We talk back to authority. Might be involved with, bullying, etc. So the way that we see this show up in nursing school, right, with our students, these can be ones who, might be really kind of what we think of as type A people, right? Constant perfectionists, have a very high standard for themselves and for others. Those who, when, they get a question wrong on an exam and during exam review, rather than just receiving what the correct response is and, kind of agreeing with it, they fight back. They tell you that you're wrong. They really want to kind of fight for it because it feels very uncomfortable for them to be quote unquote wrong, right? To not have the right answer. And in order to regain that control and safety they feel, their brain thinks it would be better for them to fight with you rather than to acquiesce. So let's just hold, that reality as we think of our next response. So this is flight. Okay, this is someone who their brain has said it is unsafe here. This is not good. And they are going to run away to seek safety. So they might seem distracted, disengaged, right? They might have, external signs of anxiety or panic. They might leave a space unexpectedly. They can't sit still or relax. They're rushing around constantly. We also see this with our perfectionism and overachievers. So both of these kind of hyper aroused states, fight and flight kind of comes into it. And this might be someone who, when something bad is happening, when a student, there's a code going on, there's something emergent happening on the unit, you can't find them anywhere, right? You want to have a conversation with them about what's happening. You want them to be able to observe what's going on. They have gotten out of it. Their body has said that they are not safe and they are hiding in the break room or in the supply closet. And that is done to promote safety. And so, our job as nurse educators is to, note that when it's happening and to speak through other ways that we can calm our nervous system down when we are feeling activated like that to better prepare them for emergent situations that might happen in the future where it will be their job to stay present there and they really don't have the opportunity to hide, to run away. So freeze. So this is what happens when, the brain has told us there's something unsafe happening and the person just feels like they are unable to seek control or safety. They literally can't think through a way that would make them feel better. So we might see them giving up quickly. They might seem to have like brain fog or be really spaced out, have difficulty making decisions about what to do next, difficulty taking action. Right. So this, shows up with our students when we're talking through a difficult situation. Maybe this is, outside of the clinical environment, even just talking through in simulation. Okay, what will we do next in this situation? If they've been activated by what's going on, they are perhaps not able to make that decision. They literally feel frozen by their indecision and they want to just kind of hide and they seem very overwhelmed by what's going on. And then our last term response is the fawn response. This one is the idea of the person recognizing, ooh, this is unsafe. I do not feel good here. I'm going to acquiesce control. I'm going to give up control of the situation in the hopes that that will make me safe. If I just kind of go along with what's happening here, I will end up being safer rather than trying to fight back or get out of the situation. So we see this often with like people-pleasing behaviors, folks who are going along but seem kind of disengaged from what's happening, what's going to occur, kind of the next plan of action. We see codependent relationships, folks who have poor boundaries. And, unfortunately, these folks are easily exploited by others. They don't do a great job of speaking up for themselves. I want to call out that I think this is one of the ones that is most difficult to recognize within nursing because in some ways, our training and going back, historically, the way we were kind of designed to be, handmaidens to physicians, and to support so many other things happening in the healthcare environment, is that sometimes nurses have kind of been trained to just fawn and go along with the plan, right? To just say, well, I guess that's what has to happen. And even though this doesn't feel good to me, I think if I just agree with this plan, it's going to get me and my patient just through the situation the quickest, and then we'll be able to kind of deal with the damage from there rather than trying to fight back in the moment. And this is one of those ones that we can, I think, prepare our students the best to transition from that into finding ways to advocate when we feel activated like that, to calm our own nervous systems so that we can show up as trauma-informed advocates for our patients and for ourselves, rather than just fawning our way through it and then needing to deal with, the detritus from there. So now that we've gone through all of those stress responses, let's just take a moment to think back to how our nervous system responds, what the sequence of engagement is. And ultimately, we want a nervous system that has the capacity for stress without moving into one of those protective outputs, into one of those stress responses. So when we're working with and regulating our nervous system, we have a huge opportunity to think about how we show up to others. How does regulating our nervous system help not only us and how we feel moving it, but how others feel interacting with us? When we look at this, and this is the hand model of the brain, right? We're going to think through that a little bit more later. But when we picture, our brainstem at the bottom, that's when where all the regulation is happening. Up in our limbic system, that's where we're getting into more of the, relating to each other, our emotional, responses. And then at the very top in our cortex, frontal cortex, we have our reasoning, right? Those that separate us from the other mammals, how we think through difficult situations. And a note of that as we keep kind of looking into recognizing and responding to trauma, I want to call out that there is at times a weaponization of resiliency, uh, believing that, if we've been able to deal with trauma, everyone else should be able to deal with it just as well. And so I want to call out, a couple of different things around expectations that everyone has access to the same resources and supports to respond to trauma. When we do this, we can end up kind of blaming someone else who seems unable to respond to stress in the same way as, we can, or other members of the team, other students we're interacting with. And so we have to remember just the inequality that exists in chronic stressors. And there's two, kind of main ways of thinking about that. One, the sociologic theory of weathering hypothesis, which particularly looks at the fact that Black folks may experience earlier health deterioration as a consequence of the cumulative impact of repeated experiences of racism, socioeconomic adversity, healthcare disparities, political marginalization. Unfortunately, the list goes on. And this is closely related to the biological theory of allostatic load, or recognizing how on a physiologic level, when we have high effort coping with acute and chronic stressors over years and years and years, it has a profound effect on our health. And that may cause a disproportionate physiologic response. So as we're talking through the next steps, I just want us to be holding this awareness as we consider our own identity, our teams, who we educate, and what we may know or not know about this kind of chronic stress and how it might be showing up in our students' lives. So as we think about strength-based components, and I apologize, I think my slide, no, it's gone away. Okay. So reminding, just when we think through the strength-based components, just remembering that there are multiple components that influence our ability to respond effectively to our reality and navigate expected stress and adversity. So, one of those things is to recognize we want to be coming with awareness for all of these differences that folks hold and different, access to resources that they might have. Recognizing that, each of us does have the ability to activate our own strengths. We all have different access to it, but it is there. And when we think about resiliency, recognizing that it fluctuates, right? Our ability to be resilient and to activate those strengths is going to depend on what else is going on. Our capacity to recover quickly, from difficulties is going to vary. We have all experienced that in our personal lives, I am sure. And so just remembering that that's going to show up into our students and not to be, surprised by someone who is typically able to work through all this and is suddenly struggling. Recognizing that we do have different protective factors, connection and supportive relationships that we can lean on. And it can be helpful for our students for us to kind of call out some of those, to recognize how those show up, to talk about the importance of spending time with our, by ourselves, spending time with loved ones, tuning into, mindfulness around the relationships that support us and those that don't, to think about how that impacts overall how we feel and how regulated our nervous system is. And as we consider our own strength-based components, what we are able to turn to cope with, our resilience, thinking about how we can increase or improve these factors and how it's varied by experience. And speaking personally, that's one of those things that can be really helpful to share with our students, right? To remind them that we are, in fact, humans as well, that we've gone through some of these, and to talk through and share times that we have been able to access some of these, kind of strength-based components of our own health and well-being, and times that it's been really difficult for us to do that. Lessons we have learned along the way that can improve our ability to do that. All right, so we're going to come back to this hand model of the brain and thinking about how we show up to others. So you can hold up your hand now if you want and picture this. So we'll know, our wrist area, that's around like where the spinal cord is, the base of the skull, our brainstem is coming out like the bottom of our palm. Think of our limbic regions as our thumb, right? The hippocampus and the amygdala, they're kind of there in the middle. And we're going to do this, and then all the way at the top, right, is our prefrontal cortex. And when we fold our fingers over, we can see like our cerebral cortex there. So visualizing that from the bottom, our lizard brain, right? The midbrain is our thumb, right? And our fingers have that top part of our brain that really differentiate us. When it's all working well, when we have that closed fist, everything's happening very efficiently. All of those parts, lizard, mid, and top brain, they're all communicating effectively. But when we are responding to stressors, when our brain predicts a potential, trauma or stress happening and it gets activated, we flip our lids, right? So lift those fingers up. We can no longer access that upper brain, right? With the logic, reasoning, and critical thinking to help us. Okay. Now, when we open up that, now look at your thumb. It's just splaying out there, right? We have all those big feelings, anxiety, our fears. They're just hanging out there for the world to witness. And so when we picture that, this is how we show up, and this happens to us too, not just our students, of course, right? So when we think about this sequence of engagement, we need to first regulate our own nervous systems, support others in regulating their nervous system before we can expect to relate with them in the middle, and then ultimately to reason with them. We can't have productive conversations or a corrective action conversation with someone when they aren't regulated. None of that is going to land. They're not going to be able to receive it, and it's likely to just intensify and make the situation more difficult. So when we think instead about using that bottom-up approach, first we want to engage and regulate, support someone in getting their nervous system to feel safe first, then relating to them, right? How do we show that they are valued, that they are part of this team, that they are liked and appreciated before we go on to reason and critically think? And we just can't be expected to solve problems or be critical thinking when our lids are flipped and we're in that triggered or reactive activated state. So how can we recognize this when we all don't walk around with our, hand flipped up when we're activated? So thinking through these different signs that show that someone might be activated. So there are different ones, right? All of these are like some sort of inability to cope, right? There are physical signs, cognitive, emotional, and behavioral. Again, not an exhaustive list. There's plenty others here, but thinking through the physical, how might hypo or hyperarousal kind of show up in folks' bodies, right? How might they be moving around, right? Really quick, kind of flitting to and fro, uncoordinated movements. How might they have really low energy or seem just like they're unable to physically stand up and engage and go on? There might be somatic complaints that go along with them, which, do not make them any less valid or real if they're caused by trauma versus something else, physically happening. Cognitively, we might see an ability to concentrate, memory lapses, learned helplessness, right? Which can be very frustrating to watch and work through, intrusive thoughts. Emotionally, we might see folks who are kind of detached or numb, some more social isolation, depression, guilt, shame, fear, avoidance. We can imagine how all those show up. And then behaviorally, we want to watch out for, substance use and abuse, eating disorders, compulsive behaviors. And that makes sense when we remember that folks are seeking control and safety. And so choosing to self-medicate to control our, behavior with compulsions or eating, disordered eating, all of those are ways to regain control in one area if we feel that we don't have control in other areas. Thinking about how it's showing up in interpersonal relationships, how is that causing problems, with loved ones and any anger related issues there as well. So when we recognize this, leads us to our trauma-informed approach. These are the 4 R's, which come right from SAMHSA again. So, first is realizing trauma is universal, which we've covered at this point. Now we've gone on to recognize, right, these signs and symptoms of trauma and how they might show up in students, ourselves, throughout others in our organization. And then responding by fully integrating knowledge about trauma into our policies, procedures, and practices. And so a lot of that is what we talked about at the beginning about how we do not need to know someone's trauma history to have plans, to have awareness of trauma worked into our policies, to have procedures that can be activated for folks who are going through something difficult, to allow for the nuances of being human, right? And having, procedures in place to make sure that we are checking in with those who are showing signs and symptoms of trauma, that we are circling around with others and they don't get lost. And then actively resisting re-traumatization, and that is a huge one about this and one to continue to talk to with your organizations. How do we create an environment that is not going to inadvertently cause more emotional and biological stress? How do we do that in ways that acknowledge, the high stakes nature of, nursing school and the testing that is involved in it, while still supporting folks in regulating their nervous system, in not adding unnecessarily to stress or creating more trauma through our learning practices, let alone what they're exposed to with, patients in the clinical environment. So the 6 key principles that we talk through with that are safety, right? So, and this is as defined by students. So safety includes, well-lit parking garages and getting to clinicals with safety, and also safety in our interpersonal interactions with, their fellow students, with, nurses and patients on the unit, with us as faculty within the organization. So collaboration and mutuality. So how do we find ways to level the hierarchies and power differences between, other disciplines, between, ourselves and our students? How do we disrupt some of those power dynamics to create more safety? And then voice and choice, right? How do we empower, how do we listen, validate, and elevate the voices of our students? How do we call out the strengths and abilities that they have? How do we incorporate their ideas and student-driven improvements to our policies to make sure we're showing up for them in helpful ways? How do we recognize cultural, historical, and gender issues within nursing education, moving beyond stereotypes and biases, understanding the history of the people we serve, and different cultural connections and community that exist there? And then trust and transparency So we mentioned this at the beginning of those reflection questions, right? But how are we consistently showing up for others? How are our actions perceived by those around us? How do we authentically build and maintain trust with our students? And thinking through peer support, right? How do we elevate our student connections, right, and the student body? How do we help them to share their lived experiences with each other to promote healing, right, amongst themselves, to lift up, from older to younger, to navigate some of the traumas that are, inherent with joining the healthcare system, with understanding challenges with patients. And so holding all of those principles, right? And these are big things. These are not, specific ideas. So holding all of those, I want to just cut a couple of things that trauma-informed care is not. Okay. Trauma-informed care is not about just focusing on negative events. It's not an excuse or justification for, unacceptable behavior, for flaunting the rules, for, not following procedures or not, being safe with our care. It's also about not just being nicer, right? Nice is not kind. And it's not just about doing one training and then, nothing else. Becoming trauma informed and then living that out in our practices and our action is an ongoing process of looking through what we have learned and understood about our practice, about how we interact with our students, and continuing to interrogate those behaviors to understand how they are showing up, how they're being perceived, and ways that they are supporting our our neurobiology, the ways that they are contributing to stress responses, and then course correcting from there. And with that note, when we think about all of this, an acknowledgement that there are many different stressors and causes of trauma within our work. Secondary traumatic stress prevention is a big one. It is one, like we said, that's been really well studied, and so we have a lot of data around it. When we note about, we want to talk to our students about secondary traumatic stress prevention. It's one of the big things we can do for them as they enter their careers, as they start what will likely be decades within the healthcare system and exposure to these types of trauma. So we can provide workshops and education, right, that raise awareness of this, that talk to them about their nervous system outside of a lecture they may have received about it in one of their classes. Understanding, offering opportunities for students to explore and understand their own stress responses, to walk through some of these examples, to share with them some of these signs and symptoms, and to see if they can recognize themselves when they've showed up, when they felt activated, what stress responses they see themselves moving into, and different ways that they can work through that. To host meetings, or this is another great way to have peers involved, right? To address feelings regarding difficult patient interactions, to allow a space beyond, a quick post conference to delve into more difficult situations, and to encourage and incentivize things that we can do well for ourselves to increase that window of tolerance, right? Physical activity, yoga, art, meditation, music. Are there ways for us to create and support activities and events that promote that, to give them the same sort of weight that we do a lot of the other stuff through nursing school and all of our testing and prepping? How can we also support our the mindfulness piece and for our students, and let them to see that that is also very important to them developing skills as a nurse to maintain throughout their career? And then noting, beyond that, you know, most of us are not trained to diagnose PTSD or post-traumatic stress disorder. It is not an inevitable part of trauma, of experiencing trauma. But if we are seeing these kind of signs with our students, that it's moving beyond, right, that acute stress. So PTSD is something that typically lasts longer than 30 days, right? Folks feel like they're, flashback into the moment of the event. Their body feels like they're experiencing it again. They might have nightmares, avoidant habits, negative thoughts, and a lot of those like hyper aroused states. Those are folks who really need to get access to professional help. There is no expectation for us as educators to be these behavioral health experts and be able to diagnose or treat that. But we want to know when to make referrals, when to express concerns, and to help folks to get connected to the resources that we have at our institution. And there's more information in the handouts about PTSD. So, as we think through this, recognizing that what got us here might not get us there, it is really essential for us to incorporate trauma curriculum and trauma-informed care practices into our nursing programs. This sets up both our students for better success dealing with patients and supporting their patients, and it sets them up for great greater longevity within, the healthcare system and greater overall well-being. So we'll talk through a quick little exercise, and then there's, space on the handout for you to do this on your own as well. But thinking through, behaviors and actions of trauma responsive leaders, right? How do you show up to lead a situation as, the educator when we see something happen that might be kind of activating for us? So, for instance, what if we see this behavior? A student nurse snaps at the instructor in the simulation labs. That's not how they told us to do it in class. Whew. Okay. Doesn't feel good to see that, right? Many of us might feel activated by that as well and be ready to provide some kind of swift corrective action. So we might be assuming, right, that this person is unprofessional, they're difficult to work with, that they're disrespectful, that they're not paying attention. But we know there's a connection to trauma and behavior. So when we think a little bit more about what we know about trauma, we can remember that students may be trauma survivors themselves. They might have experienced vicarious trauma, and that this can impact their ability to regulate their emotions or cope with stress. So when we think back to those key principles, we can come up with a strategy to address this behavior. Again, this is not about like letting the student off the hook or ignoring, right, this inappropriate outburst, but providing a way of connecting with them first using those key principles to really get to, the bottom of it. So for safety, right, provide an opportunity to check in with student to identify stressors. So this might be someone who we ask them to like, hey, let's come to the side and talk for a moment, right? And start with that. Wow, I was surprised to just hear you speak that way to instructor. How are you doing? Right? Check in, understand what's going on, right? Offer some peer support. Is there a way for them to connect it with other nursing students? Is there, are there people who are offering support groups or ways to check in? Empowerment. So how can we, offer with the student to confirm the procedure in their textbook or guide? How can we talk through, oh, I understand you're frustrated because it seemed different today than what you discussed in class. When we talk through the options of how we can look that up or how we could have brought that issue to the instructor's attention in a productive way that would have led to a good discussion for the other students as well, or for us to all learn better. And then reiterating, clear, consistent expectations around behavior, in the simulation center, what we expect and what kind of amends they need to make moving forward. And noting that this is all how we foster strength and capacity building. We want to provide ways for the student to build up their own ability to respond to these stressors in the future in better ways that, because we know that challenges like this will persist. Okay, so I invite you to think through, your own example. There's space in the handouts for that. And I'm sure all of you can come up with a few that come to mind there. But considering those examples, with students' behavior, with another colleague's behavior, and how you can apply some of these principles to show up a little bit differently and more trauma aware. And then as we go on to these, next steps and bring this into practice, know that you do have a business case for justifying this to, your leadership. If you are wanting to add in some other supports for students, knowing you can speak to the impact of improved student mental health when we have a trauma responsive education place, increased memory recall and attention, better performance and academic success for our students, and long-term better retention within the system and better career satisfaction. So all of these are really, really impactful. Nursing students have been found to use more maladaptive coping strategies than students of any other major. So we have the ability to provide them with better resources, better ways of understanding their nervous system, and improving their response to stress to have these huge long-term impacts on their mental health, on their sleep, on their performance, not only in the program, but on and on throughout the rest of their practice. Nurses who show up with their full brains, right, intact, are able to provide this trauma-informed approach to patients, to families, to each other. And here's what the research shows us about the type of sports desired by those who experience psychological trauma, particularly, acutely during the context of their job. Notably, several studies found that nursing staff were unaware of where or how to seek additional resources. And so we want to make sure that our students are certainly aware of that, within our own organization and are prepared to then seek those out in further ones to be prepared. So, one, we want to just normalize reactions to trauma, right? That's a big piece of just talking this through together before something happens rather than waiting for an impact. We want to provide advanced warning and debriefing around trauma-related topics to provide opportunities to talk through it, to understand how, and to normalize our emotional responses. We want to be sensitive to students' prior trauma and mistreatment, provide opportunities for students to process, to excuse themselves when needed, when something might be too activated, to access information in a different manner. We want to be able to have, teach skills related to trauma-informed care in simulation to give students a safer space to practice some of these, with scripting around it to bring their knowledge of that, into their practice. We want to create a baseline where faculty, preceptors, lecturers, clinical instructors, they're all TIC educated, that we're all kind of speaking the same language here. And that TIC isn't just reserved for, special modules or one course, that it's really woven into all of our existing courses and then into our practices that we come with. Hearing from guest speakers can be very powerful as they share their personal stories. And, making sure that this comes up in clinical and classroom discussions as we work through difficult situations. So, next steps for you all, thank you so much for hanging in here, is to familiarize yourself with the current student resources at your institution. Is trauma-informed care integrated within your program? Do you have some way for students to access complementary counseling through, student mental health services? Is there peer support, SNAP, a student nurse association that helps folks to get that sort of peer support and, an access to talking about issues as they're developing, as they're going on? What else do you have available outside of that? And then in the next, few weeks, how can you check in with your students? How can you understand what supports they would like to see that they either have not had access to, that we need to, create, or that they want to see changed or delivered in a different way? And then in, the far term over these coming months, thinking about the implementation process, how can you involve, your stakeholders, both staff and students, into, creating a more trauma-informed education space? How can you get, more training for you all to show up the way you want to in this, in these environments? How can you make sure that everyone is supported in creating this reality together? So, whew, as we wrap up this time together, I invite this time for you to intentionally downregulate. So feel free to extend that exhale of your breathing if that feels good, or to go into whatever form of breathing you may like. If extended exhales don't feel good for you, you could try, box breathing, where we inhale for, let's say, 4 seconds, hold the breath there before we exhale for another 4 seconds, then exhale for 4 seconds, and hold at the bottom for 4 seconds before our next inhale. And you can keep going around, inhaling for 4, holding for 4, exhaling for 4, holding for 4. You can also use the body scan that we did earlier, or any of the havening techniques. So thank you for showing up in this time together. Thank you for working to create safety for yourself, for your own nervous system, so that you can show up better for everyone else. I appreciate this time together. I welcome you to reach out with any questions that you might have. I will put my contact info on the next slide so you can find me here. I am available at Your Birth Partners. Would love to see you, or I'm Maggie at yourbirthpartners.org via email. Thanks, y'all.